First, I don't have any financial interest related to this talk. I'm from the south of Brazil, from Sabato Ghanem Hospital. We are 32 ophthalmologists there, and 6 that do cornea, 5 that do DMAC, so we have a good DMAC team there. The DMAC with anterior chamber IOL is our first topic here today, which our experience is with the aphakic artisan, so that's our preferred backup lens. There's no need to remove the lens if there's no corneal touch. So if the lens is in good place, even on anterior or posterior surface of the iris, you can leave the lens there. The surgery may be more difficult, and anterior chamber may not shallow, because many of these patients, they have anterior vitrectomy. So what you may expect is, even when you have a good graft in the anterior chamber, but it's in a good position, the double row, but you press them, you try to make the anterior chamber shallower, but sometimes you may not get it. So you have to really sometimes use different techniques. I'm really unfolding this graft. Of course, there's touch of the graft with the anterior surface of the lens. But you have usually to use this small bubble technique. There are bubbles that help you to unfold the graft. So this is what we usually do. There are some papers published. The one is by Dr. Mel's group, showing that when they have the anterior chamber iris claw lens, which is the artisan, they usually live in place. But when they have angle supported lens, they will remove it even in aphakic and phakic patients. DMAC after PK is another challenging situation because the posterior cornea is uneven. We heard from Dr. Price yesterday that this may increase a lot your chances of detachment. So expect the rebubble and tell your patients they might need it. Another thing is usually these corneas are not very transparent in the periphery, so you may get a difficult seeing that. So there are some issues when you're doing DMAC after PK, and one is graft size. There's no consensus, but usually we do the same size as the PK graft, so usually 8 millimeter. The decimal stripping is controversial. I usually strip on the center area, but there are some surgeons, they don't strip at all. But never strip in the graft host junction. I'll show you a video, old video of mine that I'm stripping the graft host junction. The unfolding may be challenging also, but usually you can manage to open these grafts if you are a little bit experienced. And check that we got 15 eyes with graft detachment and 1 primary graft failure, so you have to do rebubbles very often. So this is a first patient I did. I was trying to do the stripping on the periphery, and actually got just the posterior part of my graft, so don't try to do that. Only go for the center if you're doing stripping. It's also controversial if there's a greater chance of detachment when you do not strip the central area. It's kind of not proven. DMAC, this is a more recent case of DMAC after PK. You can see we are unrolling the carpet in a usual manner with 2 cannulas and a spatula. And when it comes to the periphery of the graft, where you have that ridge of tissue in the posterior cornea, you may see usually these folds of the graft, and you really feel that you may get a detachment. However, after rebubbling, that's usually solved. So you can see there you have that fold of your graft. This is a paper by Dr. Price some years ago in 2013, where he did DMAX and DMAX, and 3 out of his 4 DMAX he got detachment, partial graft detachments. So I'm sure now he has many more cases than that. But still, he told us yesterday that there's a graft detachment is much higher. This is a report of 5 patients last year, and all of them got detachment. DMAC after posterior porcelain vitrectomy, I think this is the hardest situation. and aphakia. When the patient is aphakic, you can think of DMAC, of course, but you have to usually consider that you have a good iris anatomy and you will be able to put an IOL. In this patient, I haven't had an experience of doing DMACs in really aphakic patients where you're not able to put an IOL. The problem is that when you're stripping the descemet, it's difficult. I don't use viscoelastics at all, I use air, and air goes to the vitreous cavity. And when you're trying to open the graft, usually what you see is that, again, the anterior chamber does not get shallow, so the air bubble technique, the small air bubble technique is the one I prefer. So here I'm doing the pupilloplasty on the superior part of the cornea, the iris, and then the inferior. I'm not using viscoelastics. I feel in these patients when they have vitrectomy, the visco goes to the vitreous cavity and they may get back to the anterior chamber afterwards. So I usually try not to use them. And now it's the hardest part again. You're trying to unfold this graft. See, I could inject it in a double screw position, which is the preferred, the easiest one. But you go and you unfold a little bit and you try to put the air bubble like I'm doing here. You're able to open it in a usual manner, but they close again when anterior chamber gets deep again. So you don't have the vitreous pressure to help you here in the DMAC. You want that. So I'm trying to put the small air bubble, but I'm not able here. You can see I just remove the air bubbles, start it all again. And what I usually do is to put pressure on the graft and at the same time put an air bubble so the graft will stick in place, and then you do some maneuvers. Now I'm doing like touching on the descemet part of the graft and unfolding this graft finally. This is a 1 month post-op. The cornea is very clear, and now let's go for the last case. This is a female patient. I think this is the hardest case I've done. 50 years old, single eye patient, so these cases are usually very hard. There's a previous PK, you can see here a previous PK, but this patient, she suffered a blunt trauma with IOL bag extrusion and opening of the graft host junction. And you can see that this is about a year after that. She still has some stitches there, but anterior corneal surface was fairly good. You can see that the cornea is very cloudy. There's vitreous in the anterior chamber. So what I'm doing is anterior vitrectomy. I'm releasing this anterior synechia. You can see here. After anterior vitrectomy, you have to deal with the descemet membrane. I'm stripping the descemet in the central area. Again, it's not easy because air goes to the vitreous cavity. And doing the pupilloplasty. After that, we are doing the inferior iridectomy. I usually do this way. It's very easy to do with 23 or 25 gauge forceps. And now using the vacuum fix to enclavate the artisan lens. And now, again, to open the graft usually wears harder. I'm doing some touching techniques. I'm trying to position the graft centrally, and now I have to use the air bubble to hold this graft. And you can see that the air bubble helps you also to unfold the graft. You will see that this bubble here is opening now. I'm using the bubble to really open the graft because I was not able just by tapping. So this is the end of the procedure. I'm doing just some bubble bumping. 5th post-op day, detachment of the graft. You can see that on OCT. We did rebubble with SF6, had position 48 hours, and this is the patient 1 year afterwards. Good cell counts, the patient very happy with 20/30 vision. So I think DMAC is very rewarding after that. Thank you very much.